आता तिकडे घेऊन जा. आता त्या रूम मध्ये बस. Is it audible, sir?
Is the voice clear? No?
We can hear, but there is some disturbance. But I think we can start, sir.
Okay. Friends, good evening to all of you. Dr. Gandhi Garu, our chairman of Genome Foundation, he himself is an expert in forensic sciences. Okay, he's the founder member of Genome Foundation. He would like to share with you a few words and greetings for all of you. Dr. Gandhi Garu, please. Dr. Gandhi Garu. Dr. Gandhi Garu, please.
Yes. A very good evening to everyone. First of all, I welcome the speakers of today, Dr. Sampada Kulkarni-Irlekar and Dr. Anil Jalon and Dr. Bubbu Anand Kumar, who is yet to join, and of course our own Dean of Research, Dr. V.R. Rao, who has thought of this webinar series about 5 months ago, having seen successfully several patients having rare diseases and having got experience of genetic diversity as director of Anthropological Survey of India, research work done at different universities, including Delhi University and CCMB. With all that experience, and also studying a lot of variations in the Telangana region, especially beta thalassemia and sickle cell anemia. And when we started undertaking cases, he came across several cases, and we thought for dermatology, this can be a study, a knowledge enrichment exercise. We will undertake this as a series of seminars, webinars every month. Background of Genome Foundation, and myself was heading the Andhra Pradesh State Forensic Science Laboratories, and Dr. Lalji Singh was heading CCMB. When we were about to retire, we will do something as a professional social responsibility. I have started Truth Labs as the first independent non-profit forensic science laboratories, which is now working from 6 metropolitan cities. And together, Lalji and myself, we have co-founded Genome Foundation as an initiative, especially for screening genetic diseases in the rural areas who are almost neglected and who are not able to access to any medical facilities. With that initiative, we have started, and unfortunately, Dr. Lalji Singh suddenly died. And in 2018, the mantle fell on me. Since then, Dr. V.R. Rao and several others, including Dr. Kanakabhushanam and Dr. Vishnupriya and Dr. Paripalli recently joined, all of them started supporting me in doing a lot of work. Dr. C. Rangarajan, former Governor RBI, was our chairman till recently. And now Sir K.V. Chaudhary, former CVC, just retired CVC, is our chairman. With all the seniors supporting us, we are trying to go trek the path, which is a difficult path, slowly but steadily. And this exercise of having these seminars is going on smoothly. The only thing is, we are expecting many more dermatologists to take advantage of this. During COVID time, it was difficult, but still we are finding it little difficult. I am sure that the scientists and dermatologists here, especially the couple, Anil Jalan and her wife Sarojini Jalan, will help us in having more people take advantage of these this knowledge which we are gained. And of course, Dr. Raghavendra V.R. Rao has been sharing his experiences with the different patients with the different rare diseases which he has identified. Today, he is going to present one of the disease identified. And I welcome all other participants. I am able to see a few of them. I welcome all of them, and I hope that in next 5-10 minutes is our experience. People join 10 minutes later. So Indian Standard Time, I think we have to give this kind of. So now someone joined now. Hopefully some people will join. Now, with the advances in genetic technologies, working knowledge of the principles of genetics is important in the evaluation of patients with complex diseases across all medical specialties. In dermatology also, genome-wide dissociation studies have generated novel insights into the immunopathogenesis of psoriasis, atopic dermatitis, and alopecia areata, and several others which we have also identified in Genome Foundation. Familiarity with inheritance patterns and available genetic and molecular tests are therefore useful in the initial discussion with the patients, diagnosis, and family counseling of patients with evidence of genetic skin disease. It is essentially and especially important given that genodermatoses encompass 560 distinct cutaneous disorders, many of which have overlapping features. And although these topics are taught in medical school and residency education, greater emphasis is needed at all levels in this age of rapidly expanding technology and increased understanding of the human genome. Given the integral role genetics play in dermatology, it is critical to obtain a detailed family history in all patient encounters. And traditionally, clinicians have relied on an in-depth understanding of a patient's medical history and clinical examination to make an accurate diagnosis and establish an appropriate treatment plan. However, in the 21st century, there has been a great advance in scientific technologies, primarily spearheaded by innovations in genetics, decreases in DNA sequencing cost, and increases in the speed and accuracy of reading DNA have moved genetics and quantitative genetic data into mainstream dermatology. We are now in an age where the global scientific community has accumulated vast amounts of public available data, including clinical, epidemiological, and molecular information. Collectively, these advances provide a platform allowing dermatology data sets to be analyzed for prospective improvements in diagnostics, therapeutics, and insights into dermatological diseases. Specifically, data obtained from patients, biological samples, or a particular disease can be compared with those from other data sets generated via highly throughput analysis of omics approaches, such as genomics, the study of gene expression changes at genome-wide level, transcriptomics, the study of the complete set of RNA transcripts that are produced by the genome, proteomics, the study of dynamic protein products and their interactions, metabolomics, the study of cellular metabolites and their processes, lipidomics, the study of the structure and function of lipids, and epigenomics, the study of how gene activity without changing the DNA sequence. These developments are being used in many more cases, in many cases in dermatology, and these multi-mix approaches have been developed in an attempt to provide precision medicine for patients while also endeavoring to deliver a holistic understanding of a system's biology and an interpretation of genotype, phenotype interactions. From a clinical setting, the challenge in using omics data is to generate concise, meaningful information without being overwhelmed by the complexity of the data. Genome Foundation is now not only utilizing their own DNA sequencing technologies available in-house and also making available all other technologies also from the outsourced diagnostic centers. So I'm sure that scientists and dermatologists who have joined this meeting today will take advantage of Genome Foundation's initiatives, non-profit initiatives, with counseling given free of cost, dedicated scientists and clinicians available with us, and doctors like Dr. Abbu Kumar and a few others have been supporting us locally on a regular basis. I'm sure that this initiative will go a long way when more and more dermatologists join from next time onwards. With these few words, I thank you for thank the speakers and also all of us who have participated, joined already in this meeting. Thank you.
Thank you. Thank you, Dr. Gandhi Garu. Friends, today the webinar is on a case presentation. Case presentation on cerebrotendinous xanthomatosis, where all the consultants here, all the experts here, Dr. Sampada Kulkarni, Dr. Anil Jalan, and Dr. Waggu Anandakumar, who told me that he will be joining a little bit late. All of them have seen this case. Okay, ultimately it is a multidisciplinary type of understanding. Now, what we said, hello, am I audible?
Yes, sir. Yes, sir. Tell me, sir.
See, precision medicine is a thing, which is well discussed in genetic parallels. Okay, genetics people talk about precision medicine, and the drug companies, they want to have a biological design drug which is specific to the disease, and genetics helps in understanding cause of the disease. But what is more important is the precision medicine should come down to the clinical practice. That is more important. Ultimately, it is the clinicians who are seeing the patients, and their understanding of precision medicine is very important, not only in the diagnosis, okay, but also in terms of, therapeutic, okay, the drugs will come out, or we will give therapeutic interventions, but also important is the family counseling, okay, these type of issues in terms of precision advice. Whatever you advise, it has to be precision. Okay, it is not exactly like personalized medicine. Precision means whatever you do, it has a precision. You know the cause you are interacting. This is what the issue here. And in this respect, what is happening in terms of precision medicine is multidisciplinarity. Clinical experts from different disciplines have to come on platform. How it is going to take place, I have no understanding at this moment. As you go through this particular case, you will understand what is the importance of different, clinical expertise in ultimately delivering in terms of family, this patient's health, helping the patient, okay, to survive and also his well-being. With these few words, I would like to introduce the experts today. Dr. Anil B. Jalan is MD Pediatrics from Mumbai University with 33 years of practice. Trained in metabolic medicine at different European centers and universities. He has more than 63 research publications, published 4 books, and contributed 17 chapters in 6 medical schools. In medical books, he has contributed 17 chapters in 6 medical books. His areas of special interest include inborn errors of metabolism, especially in critically ill newborns, newborn screening, neurometabolic disorders, LSDs, paroxysmal disorders, congenital disorders of glycosylation, neurotransmitters, metabolism defects, metabolism defects. Thank you, Dr. Jalan, for readily accepting to participate in this panel discussion. Dr. Sampada Kulkarni Irlekar completed her primary medical education from Maharashtra, Institute of Medical Education and Research, Pune. Post-graduation training at Shekhar Super Specialty Eye Hospital, Bangalore. She worked as a senior resident at Government Medical College, Nanded, and Lokmanya Tilak Municipal General Hospital, San, Mumbai. Dr. Sampada pursued a subspecialty training in pediatric ophthalmology, statism, and neuro-ophthalmology from LV Prasad Eye Institute, Hyderabad. Her main areas of interest include pediatric cataract, simple and complex strabismus, that is squint eye, and neuro-ophthalmological disorders, conditions. She also pursues research in these fields. Thank you so much, madam, for readily accepting to take part in the session. Dr. Vadhu Anand Kumar is a consultant dermatologist at KIMS Hospital. And in fact, he was instrumental when we are discussing informally, one of the meetings he told, why can't we initiate a monthly webinar on dermatogenetics? Then we have an association with the Telangana Dermatological Association. Then we started about 5 months back. The purpose of this presentation, monthly presentation, is to discuss case studies. Okay, and today we are going to share a success story. Like that, we have such success stories earlier also, and this is in fact very important in terms of what you talk of precision medicine, how we all went about it. I will briefly explain to you. This particular patient, Akhilesh, is nine-year-old boy. His teacher in the school, he thought that he is unable to read from the board, and he called his parents. He told them there is some problem for this boy. He is unable to read from the board. Then these parents took him to the local eye hospitals, and also he was referred to LVPI. And LVPI, fortunately for them, Dr. Sampada Kulkarni, he could see the case and early cataract and xeroderma pigmentosa. That was a suspected diagnosis. And while reporting this diagnosis, she also said that she found something morphologically different. That's what he said in the report. And then she was planning to have a cataract operation. Meanwhile, she also referred the case to a dermatologist. This step, is very important. Okay, and I don't know how many ophthalmologists. I have no idea the way they proceed with the cases. But this has happened to this boy, fortunately, and this boy went to Dr. Anand Kumar. Dr. Anand Kumar, after looking at the lesions, some pardon me. What he felt was that, immediately he referred the case to us. We looked at xeroderma pigmentosa genes, and then there is a suspected diagnosis, there is a doubt. We thought we should go for whole genome scan, That is one of the very, very important technologies which are made available to us, okay? About 2 to 5 years back, this whole exome sequencing, we never had that confidence. People used to do, but the confidence built up as the technology developed. And this technology can scan 25,000 exons, all coding exons. I will explain this technology. I will explain what experiments we did during my presentation. Now, what is important after this, when Anand Kumar has referred the case to us, we sent for genetic, we did genetic testing with whole exome, and we found this particular mutation, particular gene, which was involved. CYP27A1 is the culprit gene with a mutation, which is pathogenic. Cerebrotendinous xanthomatosis, that is what this gene, the mutation causes this particular disease. Then immediately I called Dr. Anand Kumar. He told me to send the patient to a pediatric neurologist. So we found Dr. Pranahita in Hyderabad. We referred the case to her, and she has seen the case, and she told us that Dr. Anil Jalal, it is a storage disorder and metabolic disorder. And what she told us is Dr. Anil Jalal will be visiting Hyderabad on this particular date. Why can't we see the case at that time? So father, in fact, he's a very poor man. He's a street laborer in his village, but he is a very, very good parent, father. Whatever we say, he will do. He has again come back and met Dr. Anil Jalan, and he has advised some biochemical tests. And biochemical tests, folic acid, that particular biochemical testing which was done, and he felt that choline insufficiency, and then he advised for folic acid, supplements. But again, when we asked him where it is available, he said that is USA, produced in USA. But we have a biosimilar done in Tamil Nadu. Okay. So we contacted that Ramachandran when Dr. Anil gave me the number. I spoke to that person. He said, sir, we do supply. And no other in the Hyderabad, in India, we could find this particular supplement being supplied. So we started in fact, Dr. Anil has started the administration of the drug, and the boy is responding. That, Dr. Anil Jalan, in his presentation, he will give us what is the improvement, how it has happened, with his understanding. With these friends, now I will request Dr. Sampada Kulkarni to present her slides. Okay. Dr. Sampada Kulkarni, please.
Good evening, everyone. Thank you, Professor Rao, for introducing and getting me on panel for such an interesting case. I just wanted to know, is my voice audible and my slides are visible?
Visible and your voice is audible.
Okay, so yeah, so we'll just go to the case straight away because we have discussed the basis of the case. So this is a case. Actually, we were trying to see that is there any differential diagnosis of cutaneous pigmentary dysfunction manifestations, and the case-based learning of this particular disorder called as CTX, that is cerebrotendinous xanthomatosis, and the importance of genotype phenotype correlation, if at all, we can do in particular cases. So this was a case. So what all things actually we see in ocular conditions where the skin manifestations can happen. The most important thing which we usually see in our clinics is a OCA, that is ocular cutaneous albinism, which is visible and has manifestations like nystagmus, poor vision, retinal dystrophies. Xeroderma pigmentosa usually associated with dry eyes, having some cancers like squamous neoplasms or limbal deficiency, particularly dry eyes. Those are the conditions which we see. Harman-Pudlak syndrome again is associated with OCA, where there will be skin lesions. They will have recurrent infections of the skin as well as upper respiratory tract. Chidiac-Higashi also comes in the same syndrome where the child may present with recurrent UTIs and small reddish dot-like lesions on the extensors. And other ones are like Waardenburg syndrome, where we see the phacomatosis or hyperpigmentation or ash-like lesions on the skins. And another differential diagnosis, cerebrotendinous xanthomatosis. So this case was actually doesn't have a cutaneous pigmentary manifestations, but this case was suspected of having xeroderma pigmentosa, which is not associated with cataract in younger age group. And this was the point where we thought that why it is happening in this kid, and we decided to further modify. So going to the case scenario, so as Professor Rao has already said, this was a 9-year student hailing from Telangana, was referred to us for defective vision in both eyes noticed by the teacher from past 3 months, and was referred by a local ophthalmologist for cataract surgery to us. There was no history of any previous glasses or any other medications taken. There were freckles present over the nose and malar area since early childhood. There was no significant family history, no parental consanguinity. Birth history was normal. There was no developmental delay. The child had no other complaints associated with photophobia or difficulty in seeing at night, repeated infections, or sunburns. So he was average in performance. There were no limb abnormalities. He had little bit of gait abnormalities like a ataxic gait, but no facial dysmorphism. His CNS normal, health functions, motor sensory system was normal, and rest of the systemic examination was also normal. So if you look at this patient as such, you can see that there were multiple small dot-like freckles which are present in the nose and the malar prominences. Along with that, the same lesions were present on his body also, like limbs and leg. Uh, he had a very sparse hair with a little bit of orangish tinge to his hair, which was present on the forearm as well as on his eyebrows as well. So this was the features which we usually see in a case where there is a malnourishment. But this child was not a kind of patient who had malnourishment like systemic examination. Uh, Vision assessment, the right eye vision was like 20 by 212 and 20 by 320 and 12. This comes under vision impairment of moderate class. But he had a refractive error of minus 3.5 spherical with 4.5. This is a moderate refractive error, which was not corrected till now, and his color vision was fine. If you look at his overall performance, when we were doing assessment, he was keeping his head tilted towards right side. Sometimes kids do in cases of uncorrected refractive errors, and rest of the things were within normal limit. If you look at this particular case of this child, you can see that these small granular dot like opacities, which are more prominent in the mid periphery of the lens, and was seen on the rectal illumination. So these are granular or flake-like opacities which were dispersed in the nuclear part of the lens, which can suggest that it is not happening at the birth, but it was present in the development stage of this child, which was present bilateral symmetrical, again suggestive of some systemic disorder in this kid. So rest of the things of retinal dystrophies were ruled out, and the child was absolutely fine except the refractive error and the cataract in his eyes. So clinical impression was he was having compound myopic astigmatism, that is a refractive error. He was having a vision which was poor, which was not improving with the glasses in the first visit. We suspected that it could be just because of the lens opacities and the uncorrected refractive error. There was a developmental cataract and the skin lesion which were suspected of xeroderma pigmentosa. So we decided the child needs glasses in the first place rather than getting a cataract surgery done, because usually we take a approach that whenever there is an uncorrected refractive error and the opacities which are not involving the visual axis and not visually significant, we try to give them spectacles and see that how the vision is improving with the glasses. We started him on patching therapy, which is amblyopia therapy, and referred for dermatologist testing for the skin lesion and is there any relation of this particular skin lesions to the cataract which the child is having, and asked him to come back after 2 to 4 months to reassess his vision and the cataract status in the follow-up. So when patient came after 2 months, his visual acuity was surprisingly very improved. It was up to 20/50 and 20/60. Child underwent genetic testing, and the background was told by Professor Rao that he went to dermatologist. Dermatologist referred him to a genetic testing, and from that we diagnosed that it was a CTX. Child went to Dr. Anil Jalan, and he was started on therapy immediately, I think within a month or so. And he came back after starting the therapy after 1 month to me, and that time his vision had actually surprisingly improved. The cataract status was not changed in this visit. I'm yet to follow up him in next month, and that's all the case was. So this was diagnosed as CTX, and yes, so CTX is basically, I think Dr. Jalan will cover, but just to get a basic idea, I thought that this slide is required. Usually the child presents with some yellowish lesions, and the cataract delay in diagnosing the condition is 16 years gap. So when I was going through the literature, it says that the cataract is early to form in the adulthood or young age, but it doesn't manifest as a visual symptoms. The child comes with the neurodeficiencies, dementia, psychiatric issues, and later on comes to a diagnosis of cataract and infantile diarrhea in a retrospect. But this case was surprisingly found out very early and was started on treatment, and the treatment response is very good in these kids. So it is autosomal recessive disorder with CYP27A1 gene mutation, which is a deficiency of mitochondrial cholesterol 27 hydroxylase deficiency. Childhood and onset disease, it usually presents with chronic diarrhea during infancy, cataracts in late childhood, and frequent bone fractures due to brittle bones. In adult, the child, usually the patient presents with dementia, seizures, hallucinations, depression, difficulty in coordination, and difficulty with speech. So this was the case which we had. Over to you, Dr. Rao, for further discussion.
Thank you, Dr. Sampada. Madam, have you seen such cases earlier?
No, Dr. Rao, this was the first time I had asked my colleagues and my seniors also. This is a very rare condition which can be diagnosed in the early infancy. So this was a very new case for us.
Okay. Now I will present, this what in front of genetic tests we did. Sorry. I did something here. Hello, Dr. Khanna? Mr. Khanna? Sorry. Yeah, I will share my slides. The screen is shared. Hello?
Yes, sir. Yes, sir.
Yes, sir. Okay, thank you. Now, you see, what is happening, in terms of the genomic sequencing and all, whole human genome sequencing, what we think in terms of 3 billion base pair sequencing, this technology is available. People do this. There are no whole human genome about 30 to 100 base pairs. Okay. Now, what we do in whole exome sequencing is only genes, coding genes. The coding genes we sequence, all exons are sequenced, around 25,000 gene exons. Okay. Now, what is happening when we do whole exome sequencing? We come across about 25 lakh variants, 25 lakh changes in the genome. By filtering at different stages, we come to the mutation, what is causing the disease. This is what the beauty of this. It is a 25 lakh variants. Among this, we are going to boil down to one mutation, one variant. See, all intronic and off-target variations we remove from 25 lakhs. Only 10% is left out. 2.5 lakhs variants are left out. And in that 2.5 lakhs, what we see is non-synonymous, about 57% non-synonymous. Non-synonymous variants are, in fact, they participate in protein production. Okay, they are coding genes, coding exons, coding genes and exons. And there are several synonymous variants, about 37%. There are stop gain and some unknown variants and small indels. We can include all these 57%, 4%, 1%, 1%. All these around 63% variants we need to look into. So that component comes to about 60%, we are now boiled down to 1.5 lakh non-synonymous stop gains, loss, and small indels. Okay, this is what the variations we have, which among which we may find our variation, our mutation. Now, what we do here is we remove all the variants which are more than 1% allele frequency. These variants, they are already in several human genome sequencing, in several exome sequencings. There are several databases, 1,000 genomes, DB database, expression database, mRNA database, all these databases all over the world, even Asian genome databases. What people will do is that if a variant is more than 1%, variant, I means, the allele, okay, the causative mutation, okay. In any mutation, in any allele, there are genotype, there are one wild variant, which is a derived variant, mutant variant, and the older wild variant and derived variant. Okay, wild means normal variant and mutant variant. So mutant variant, if it is more than 1%, we ignore them, we remove them from our list. It is not causing the disease, because all the rare diseases, the cause is by very, very, very rare variants. The particular mutation we have is 0.001%, it is very rare mutation. So if we remove that, we are left with 90,000 variants. And remove, now there is an in silico prediction, functional prediction. We can always say among these variants, whether they lead to any function in terms of mutation in the exon, where is the position of that mutation, how it is translating the protein, enzyme. All this, they have in silico models. We call it SIFT. One is SIFT. If the SIFT is tolerant, it is benign variant. It is not causing the disease. Again, we remove by polyphen prediction. This is also in silico. If it is positive, is it benign? Okay, we remove it. Like that, about 36 variants, ultimately we come down to around 20,000 variants. Okay. Now, when we have 20 variants, 20 mutant mutations, what we do is usually removing variants unrelated to the clinical symptoms. Only thing we do here in whole exome sequencing is that clinical symptoms are given in our algorithm. Okay. Now, in our case, we found that this particular gene, CYP27A1 gene, and the mutation is a deletion, one G deletion, okay, and at 526 codon. When this mutation, the report has come, then we do validation by Sanger sequencing. When I do Sanger sequencing, I target this mutation, okay. This is very cost effective. Then I do for parents, the patient, father, mother, and the children in the family. When I do that, it is a validation for me that this mutation is causing the disease. Algorithms, based on applications, constantly upgraded with world databases. Okay. In fact, genetics, a lot of things are happening in genetics. Today and tomorrow and after tomorrow, a lot of changes. It is constantly upgraded. Now, whole exome sequencing results are like this. We have the gene, we have the mutation, and this, what it causes? Frame shift truncation, okay? That is it is a homozygous condition, and the disease it is causing is given CTX, autosomal recessive, and pathogenic, okay? This analysis, this finding, inference, strongly based on the databases which you had, and also clinical symptoms, and also our filtering whatever WS algorithms we used. And we know that what is this? It provides instructions for producing an enzyme called sterol 27 hydroxylase. This enzyme breaks down cholesterol to form acids used to digest fats. The formation of bile acids from cholesterol is the body's main pathway for cholesterol removal. Mutations in this gene are implicated. This gene has already been implicated. There are several cases being described. Okay, and when this mutation also has been described in other patients, not in India, from other places. Now, this particular gene, when we look into, it is on chromosome 2, total 33,500 base pair, 9 exons. If I do Sanger sequencing of 9 exons with 33,000, it will be huge expenditure. Okay, for each amplification, I need to do about 20 or 30 amplifications, and each amplification costs 2,500. So instead of that, mutation, exon 3, that mutation is exon 3, we know it is frame shift mutation truncation. We went for whole exome sequencing of we have not targeted this particular gene. We put all the symptoms and we run the whole exome sequencing. As I have shown to you, the filtering process which you have been done that has shown this is what the culprit gene. In fact, there are guidelines. Okay, American Journal of Medical Genetics Society, they have formulated guidelines. Suppose if I run an exome sequencing, I have my mutation which is causing the disease. If I find any other pathogenic mutation, I need to inform, I need to report. Okay, this type of guidelines people follow. Here, we didn't find any other pathogenic variant. Only variant we found is this. Now we went to the family. Family, you can see here, father, mother are carriers, elder brother, patient is a 9-year-old boy. This is the normal. 2 Gs are here, okay? And once 1 G is deleted, the reading frame shifts, okay? Instead of aspartic acid, we have methionine. Methionine is a is initiated codon. It initiates sequencing. Okay. So this frame shift, truncated frame shift, given a particular protein in terms of homozygous condition, there is in terms of deficiency of this protein expression. So patient, we got deletion of G. G here there is a deletion. There is no second G. Suppose if you see the normal child, there is a second G here. Okay, sister is normal, and here one G is missing. In terms of father and mother parents, because one allele is normal, each individual has got two alleles, one from father, one from mother. Okay. Now, because both normal and truncated shifting has done here, exactly at this place we have shifting. Okay, two reads are there. So this is a in terms of validation of that mutation is causing the disease, and also it is segregating in the family and a homozygous recessive manner, autosomal recessive manner, and both parents are heterozygotes, and one brother, he is heterozygote. Okay, he is normal now, but the family, we could talk to them and we told them the results of the boy, has to be carefully preserved in their home, and whenever he is getting married, it is not that he should go for testing the girl, but after marriage also, before pregnancy, when she goes to any gynecologist, he has to show the reports. And gynecologist, when it is she's pregnant, even at PND, prenatal diagnosis can be done with the mutation. And first of all, after he marries, when they go to gynecologist, she should look for the mother's genotyping. If the mother is normal, then no need for any prenatal diagnosis and abortions. But if both are heterozygotes and there is a chance of getting a 25% chance for each child, then legally it is advisable to go for abortions. After looking at the fetus, amniotic fluid of chronic villi sampling, and the mutation can be done. If she is normal, fetus is normal, pregnancy is continued, otherwise advice for abortions. This is what, briefly I explained to you about the genetics part. Now, Dr. Any observations? You can always ask me. And now we should go for, hello, any observations, please? Am I audible?
Yes, sir, you are audible.
Yeah, any observation? Otherwise, we should go for Dr. Alin Jalan's presentation. Afterwards, we can have some discussion. Okay? Yeah, Dr. Jalan.
Hello, thank you very much. Am I audible, sir?
Yes, yes. Please.
Yeah. So thank you very much, Professor Rao. Now, this was the case which came to us with a diagnosis, genetic diagnosis. But what we generally do is, if we have a genetic diagnosis, we try to go for biochemical or some type of functional confirmation, because many times we see that the results or whatever the clinical suspicion and the biochemical results do not match, and the treatment is basically targeted towards biochemical abnormalities. So before we start treatment, I would like to confirm that it really is CTX, and how severe it is, that we will have to. Now, this case, sir, has already discussed, but
sir,
yeah,
your voice is not clear, sir. Your mic is some disturbance.
yeah.
Without headphones,
Yeah,
remove
I'm
your
also
headphones.
getting-
Remove your headphones. That is, you're using the laptop, no, sir. Remove the
Try with laptop.
No, we'll talk. No, his mic is not working. Oh, not working. Okay. But that mic is very disturbance and no, sir, my mic is not working, sir. Keep it in. Hello. Not clear, sir. Yes, sir. Wait, sir. Hello. Sir, use the headphones mic, sir. Sir, use the headphones mic. No, voice is not. There is. Sir, your mic is mute, sir. Please unmute your mic. Sir, unmute చేసి మాట్లాడండి sir. Yeah, no speak, sir. No, sir, that is previous ఎలా ఉన్నారో అలా పెట్టుకోండి సార్. సార్ హెడ్ఫోన్స్ యూజ్ చేసి మాట్లాడండి సార్. Sir, any problem?
Hello. Hello. Hello.
Hello, Karna. Is it fine?
Yes, sir. Yeah, the mic is problem, sir. I think I don't know.
Okay. Just see, whatever is possible.
But my side is not.
We can hear you from Dr. Sarojini's
Karna,
Sir.
advise Dr. Jalan to use Dr. Sarojini Jalan, his wife.
Okay.
Wife's-
Okay,
Okay.
I'll ask.
Advice.
I'll ask you, sir.
Is it audible now?
Yes, sir, clear, sir.
Yes, yes, clear. It is clear now. Yeah.
Yeah.
Clear?
Yes,
Okay.
yes,
I
yes.
think
Yes, sir,
we'll
clear.
continue with this. Okay. Only the slides somebody will have to move, and there are not many slides, just 2 slides. Okay. So this chat, I think, let's. Is it okay now?
Now it is
Shall I
better.
continue?
Yes, yes, yes. Now it is-
Continue, sir.
Yeah.
Good, sir.
Okay. I can't see my slides, so I'll have to just.
Again, you can share the
No,
screen.
that's okay. I'm just. Yes. So, yeah. So this child, he history of repeat motions, loose motions, and what father complained that he is not gaining weight adequately. That was quite nasty, and we tried to find any xanthomas or xanthelismas, but they were also not seen. So this is the usual presentation that we see in say first or second decade kind of presentation. They have neurological symptoms more, like difficulty in walking, spastic, or sometimes they have exaggerated jerks, and tendon xanthomas. Those are seen. I have seen about 6 or 7 CTX patients, and we always had these things, but this child did not have anything. Probably this is little early presentation. So can we go to the next slide, please? Everybody controlling my slides, or I have to do?
Yes, I am controlling, sir. The fourth one, sir.
Slide, Karna.
Sir, fourth slide. I think.
Okay, so
Before-
let's make it.
Yeah.
Yeah, good.
Next slide.
Okay. Second, third. This here come to the one before, one before, where this state
Karna, one before this one.
yeah.
I'm not controlling, sir. I'm not controlling.
Okay.
It
Ah,
look
this-
possible now.
Okay. Yeah.
So this slide, if we see,
Yeah.
the cholesterol, when we saw this child was
This slide, sir.
14.5. I think and generally we send in. Yeah,
Karna, next one. Yes.
Yes.
slide. No, in between that table is important.
Next comment.
No, before this. Now, what you have shown interpretation just before this. No. You are going ahead. Go back. No, we are going ahead, sir. We are going ahead. We want back.
Yes, yeah.
Yes, this table.
Okay,
Hold
sir.
on to this table.
Okay, sir.
This 4 slide, just 4 number slide. Please don't go ahead. Fourth, yes.
Yes, this one.
Just fourth.
Yeah.
So what we see here is the levels which we saw 14.49 cholesterol. These are not very high. Normally, like when we have patients with neurological manifestation, the levels are around 50 or 60. And they have all sorts of neurological things, dementia or regression, some kind of psychiatric problems. And we always see the genetic diagnosis and now biochemical confirmation. We wanted to treat, and the treatment is can we go to the next slide? Yes, so this is all the confirmation things, and let's go ahead. Now we will talk about the treatment. What is available in India is folic acid. We want some other medicines, but right now we are treating with only folic acid because that is the thing which is rather easily available. Okay, so folic acid we start of 15
Sorry, your voice is not clear, I think.
Dr. Jalan, if you have this presentation in your any other system, you can read out from that, and we need not have to show it to us. Just read out. I think people can understand this.
So what do you want me to do? You want me to read out?
Yeah, because I think when now it's clear. I don't know. No, you can go ahead. You go ahead now. Please go ahead.
Is it clear?
Yes, it's clear now.
Please go ahead. It's clear. Yeah.
Yes.
So I'm going to talk about treatment. I'm not going to discuss any theory part or MRI or anything.
Okay.
So we started with folic acid. That was the thing which is available, 15 milligram per kilogram. And his levels of cholesterol came down from 4.49.5 to around 50%. But at the same time, we noticed there's some increase in
The problem is with your, I think, headphones, I think.
going to respond so well, because there are a couple of papers which show not so effective treatment with folic acid. But I found one paper which says, yes, it is effective. and we can definitely try. So this was the thing which we started, folic acid, as it is easily available. And now second time when this child came, if we can, yes, I think let's just stick to this, or just one more slide before this. So that is the table. Yes, this is the summary of the entire. I think we should be happy with this. So cholesterol with So the next logical line of treatment is statin, and we have started him on rosuvastatin 5 milligram. Maybe we can increase up to 10 milligram if need be. So the line of treatment now will continue with folic acid in combination with statin. He does not have any side effect, and he has gained weight. Father says his frequency of loose motions has decreased. Now he has normal motions. His walking has improved. Previously, we had seen walking him with stiff gait and difficulty, and he was not really able to climb on the examination chair. Now, this time when he came, he did it himself. So his joints were quite free. There were no exaggerated jerks. His freckles I found were less. Now, I'm not sure how the dermatologist is finding him, but after seeing him, say, with a gap of 3 months, found that his facial, those small freckles, they have improved. Overall, I can say with combination of so this particular case, CTX, shows us that there is some treatment which is possible, even though we do not have the actual drug which is used here. And we found out that it is available in international market, and it's costing about $2 per tablet. And it's better that if he's responding with folic acid, we will continue for a long time, maybe at least 1 or 2 years, and see where he settles down. If he does not, then we will have to import and see whether we can help him with that additional medicine. So with this, I think I can just finish my presentation. If you want to go ahead and show some slides, like tendons, xanthomas, yes, this one. Professor Rao, do you think MRI is done for
Yes.
this child?
Yes, thank you, Dr. Jalan.
Okay.
In fact, you know, yes, please.
It's done?
Yes, thank you. Yes, doctor, thank you. Yeah. Dr. Jalan, thank you very much. In fact, you know, this is what we call precision medicine in terms of, you know, mutation-based intervention. And fortunately, you could, you know, Dr. Vaggu Anand has joined. Dr. Vaggu Anand will come back to you. Just now, Dr. Jalan has completed, he has presented the slides and the treatment part, and also the patient is responding. Okay, the patient is responding, and 3 months evaluation he has done. And also our ophthalmologist, Dr. Sampad also has presented. Dr. Vaggu Anand Kumar is the dermatologist who has referred the case to us. Dr. Vaggu Anand Kumar, if you want to say a few words. You can complete your presentation. Then we'll go for discussion. Dr. Anand Kumar?
Yeah,
Yeah.
sir. Good evening. Sorry for the late training.
Yeah.
Actually, the case referred by ophthalmologist only.
Yeah.
Anyway, that patient somehow somebody referred to me. Some patient, my old patient, they referred to me for that case. So that they came to the KIMS. Then initially also I thought it could be a xeroderma pigmentosa only. So I want to rule it out further genetical study, genetical analysis. That is the reason I sent to you.
Yeah.
The moment I see the patient also, I could not make the diagnosis.
Okay.
I could not make the diagnosis of this diagnosis. Then when I sent to you, then only then you Genome Foundation, they worked on that case and then they came to the conclusion. And then you only called me that is, you told me that this could be the possibility.
Yes.
So initially also I am unable to diagnose that case.
Right. Thank you, Dr. Anand Kumar. Now the patient, is under treatment, and he is responding to the treatment as per the evaluation by Dr. Jalan. Okay, by cholic acid supplementation. Now, one question Dr. Jalan was asking about that lesions, tendons, whether dermatologist has again seen him. Okay, I will ask the patient when he comes to us. I will send to you, have an understanding of whatever lesions. Our Sampada madam has got some photographs. She has taken photographs of the boy.
Okay.
With
Okay.
some. Okay, so we can compare dermatologically. That is one thing. But whatever Dr. Jalan has comparisons, between earlier readings, 3 months before readings, and cholesterol levels have decreased. Okay, and that is a positive sign. And also, Dr. Sampada has told us that he has improved. Sight has, that's what ophthalmologically he has improved. Now we'll come to, in terms of understanding and discussion, what I would like to ask Dr. Jalan. He has been seeing the cases. When I first talked to him, he said, this is the case, which is quite early detection at 9 years, 9-year-old boy. Okay. And as he was presenting the biochemical levels, usually patients get 50 grams like that. This boy is only at 14. And is it due to early detection is going to save this boy in terms of onset of neurological disorders? Dr. Anil.
Yeah. Hello.
Dr. Anil, in terms of, you said that is early detection is always better. We all know that early detection intervention is better. Now, if we continue this intervention for 1 year, and also we may change the drug, how is it going to be prognosis in terms of neurological onset? You have brain scans of this boy?
I have not seen, but
Okay.
if you have, I think I would like Dr. Pranati madam to see it,
Yes.
the neurologist. But currently, like this time when he had, madam was there, we both of us evaluated him and she didn't find anything really significantly affecting his brain.
Yeah.
Initially, he had difficulty in walking.
Right.
No extra
Yeah.
pyramidal sign or pyramidal signs and on the examination table, but this time he was very relaxed. He could do all this activity.
Yes. That's what
His
we call
jerks
out
were
the
not
times.
exaggerated. So
Yeah.
I don't, yeah. So what I feel is like if we treat him,
Yeah.
the further neurological deterioration definitely be controlled.
Control. Yeah. That is a
Definitely controlled.
very encouraging, And
Yes, sir.
otherwise, I was explaining, all your adult patients, with adulthood, they all have set all
Yes,
the
sir.
neurological setting, That,
Yes, I'm just coming to that because Yeah. See, we happen to see at least, I think, in my record, about at least 5 to 6 cases.
Yes.
And his levels, initially, we were little worried why these levels are so low.
Okay.
So Dr. Ketki is there in our panel, like she's the one who does this analysis.
Okay.
And she came to us like, is it really CTX?
Yeah.
And then, of course, we searched the literature and they said, yes, it can be, because the levels can be low in early cases.
Okay.
And this fellow is around 14, 15. So I think it's just almost 15, 20% of the levels which we can see.
Okay.
Now, what we see, second decade presentation who come to us, they always have neurological problems.
Okay.
More than skin, their presentation is neurological.
Okay.
So they will have all these exaggerated jerks, psychiatric problems, cataract, and tendon xanthomas.
Yeah.
And difficulty is like we are not really able to get these medicines. So
Yes, yes,
in
yes.
adults, whatever I have seen,
Yes.
I have not seen any good response. Now this child has shown good response. So
Yeah.
I'm really hopeful that
Yes.
if they continue, the
Thank you.
cost is
Yeah.
an issue. Yes. Yeah.
Yes,
We have discussed about this.
Yes,
And
I should tell to our friends here that Dr. Jalan, see, this medication, it costs 14,000 per month. Okay. And he has to take 2 tablets, 2 capsules, morning and evening. And that fellow, that father is a laborer. And Dr. Jalan is kind enough to arrange 4 months medication for this boy. Okay. I must, in fact, compliment Dr. Jalan with big claps. If it was a physical meeting, I could have clapped. This is what, again, they have referred to another hospital, that particular person. He has promised 6 months medication. So this type of, approaches and help, is required for this patient. In fact, this boy, we have saved him. By early detection and intervention, whatever is possible from our point of view. Dr. Jalal, I must thank you for arranging, this medication for 4 months. Okay, and I think in terms of periodical evaluation, after 3 months, I will ask him. He will meet you, and also kindly look into neurological evaluation. If a mRNA scan is required, one basal
Yes.
scan, we should have a basal scan, and so that we know what is happening, and even understanding this, it will be of importance to scientific community.
correct. Sure,
Yes.
sir. Sure, sir.
Dr. Sarat Chandra want to have some question. Dr. Sarat Chandra, you can ask. Dr. Sarat Chandra? Dr. Sarat,
Yes, sir. Yes, sir. Yes, sir.
You can ask the question. Yeah.
Yes, sir.
What
Sir,
is
I
it?
would like to know about the pathophysiology of this loose motions. Why at all there are loose motions in these kind of
Dr. Jalan, can you answer? Diarrhea is a classical diagnostic for this. case.
Jalan on mute.
Dr. Jalan, it is something related to bile acids, no? Bile acids.
Yeah, it is related to bile acids,
Yeah.
but exact pathophysiology, why they have loose motions, and all of them.
Right.
Like, has
Now the loose motions are
patient,
controlled.
and just before this meeting, I tried to look up. This is the only patient who has loose motions. Mass depression, exaggerated jerks, no loose motions. Rest all 5 patients, nobody had loose motions.
Oh.
But it is described like because my slides were not clear. There is a scoring system. If you see in scoring system, chronic loose motion has been given
Yeah.
a score of
Right.
And diagnostic, share my slide, is it, or I'll just give you a brief.
Yeah.
So there, this scoring system take to account neurological manifestations,
Oh, okay.
peripheral neuropathy or exaggerated jerks or seizures. All those things are given
Yes. Yeah.
25 each, and chronic loose got some importance. And MRI picture with the dentate nucleus hyperintensity has been given score of 50.
Yeah.
Sibling affected has been a score of 100. So it is quite specific. But if you see, those who are presenting in second decade, I have not seen chronic loose motions or weight loss as a manifesting, but the numbers are really small. Like 6 cases is not a big number. Now, there is another presentation or history which is usually mentioned in the books or literature is cholestatic jaundice in the neonatal period.
Oh, okay.
And none of them gave this history. Even I inquired with this person, father of this child, and he was not really aware of any jaundice or cholestatic jaundice in the neonatal period for this patient. As against this, we have performed this analysis for some cases of cholestatic jaundice in the newborn period, and so far we have not picked up any CTX case. So there are some presentations which are common, some are mentioned in the books, not so common. And what we see in India, at least, is the second
Yes.
presentation with neurology.
Yeah. Yeah. Yes, Dr. Jalan, thank you. And, now, Dr. Sampada. Dr.
Loose
Sampada.
motions and good gain.
Yeah,
How exactly?
yeah.
Yes, Professor Rao, yes.
Dr. Sampada, you see, you said that you planned cataract operation
No,
at the earlier first visit, and there is then you spoke to me. I spoke to you, and he said after looking at the genetics and all that diagnosis, then what is the status of now cataract? You have to go ahead with cataract, or you can postpone, or he can improve with the whatever the response is good. That's what you have said. You are happy with a lot of improvement. So what in terms of cataract?
So usually what I have seen, see, I don't have experience of multiple cases, but whatever cases which are reversible, like in galactosemia also, usually it reverses within 3 months of starting the treatment.
Okay.
But that usually doesn't get diagnosed early, and more end of the overall evaluation of the child, we end up doing surgery. In this patient, if you see the pictures which I had shared, the cataract was not clinically significant.
Okay.
Though the granular opacities, but the vision was poor, and that was contributed maximally by his refractive error. So
Okay.
when he came to the last visit, that time his vision was improved by almost 70%.
Wow.
And this vision, he can actually will be able to manage his day-to-day activities,
Right.
because his reading has improved significantly. Even the performance at school has improved. With
Right.
this, because the cataract stages, I had taken the picture of follow-up also, and we compared also. The cataract as such is stable. It has not improved, but I think it is too early to say about cataract, because the lens metabolism is very, very slow. So it might take further some time to completely get an idea that it really dissolves or not. So I am yet to see him at 4 months follow-up. Let us hope that the cataract will go. But at this point, for this child, I'm not going to do surgery for him.
Okay.
We'll just see with the spectacles how he is doing, and with close follow-up of maybe 6 monthly or something. If still he is not able to read last few lines, then I will think about it. At this point, it is not required. Definitely not.
Very good. Thank you. Thank you. Yeah, good. From that ophthalmology point of view also. Yes.
So I just wanted to ask Dr. Jalan that he was telling about 6-7 cases of CTX. So has he come across the cataract, or were they screened about the cataract in the lenses, like ophthalmologically?
Dr. Jalan. Dr. Jalan,
Yes, madam. Yes. Yes, sir.
in your cases, what is the
Yeah.
status of ophthalmology, cataract,
All of them, sir, all of them had cataract, all of them.
Oh, okay.
All of them, because all of them were like presenting in second decade, 14,
Okay.
15 years onwards and up to 29 or 30 years. And I think by second decade, they definitely have cataracts.
Right.
And they were actually detected to have CTX just because of cataract and neurological symptoms. So this combination led physicians or pediatricians to screen for CTX. And they came with that diagnosis, like the child or the person has cataract and tendo-achelis xanthomas.
Right.
They all had xanthomas. So one
Right.
of the picture which I showed is my patient, which has quite large xanthoma.
Yeah, yeah.
So may I ask, Dr. Jalan, at what age they start having these xanthomas and the cataract grade was significant that they did surgery?
No, see, most of them never followed up with me, so I have no idea. What happens is they usually come to us for this screening, and when we give that cholesterol is high, and I have seen that table or the Excel sheet, and the levels were quite high, 50, 60, 70, like that. And unfortunately, most of them come from teaching institutes like KEM Hospital or Wadia Hospital, where possibility of medicines like this are not available. Like even for colic acid, which is cheaper medicine than the other medicine, this is about, you can say, still 7,000 rupees for a bottle of 100 tablets. And it's a lifelong or long-term medication. So I don't know whether they were started. One of the patients which I know is a girl from Goa, and mother has started, but they never followed up. I have no idea whether they operated for cataract or they are just waiting. No idea. Sorry.
Right. Yeah.
No, but what we read in our literature, Dr. Jalan, is that you ask for chronic diarrhea in infancy, or you ask particular disorders for a particular case, like you ask for hypotonia in Loeys syndrome, or you look at the phenotypic features where there is a thick nose or sparse teeth, and there is skin lesions. You look for like Nancy Horan syndrome. So the way you have described just now, that the diarrhea is not the thing which we usually see in CTX patient, this is a very new learning for me. So henceforth, if I am talking in podium about something called CTX, I would stress this point saying that the diarrhea is not usually seen in these cases, or how do we put these words of
No,
experience in our clinical practice?
see, unfortunately, I cannot generalize based on 5 or 6 cases. This is not really a great number for metabolic diseases. But one thing I can tell you, because I am seeing really hundreds of metabolic patients, and the phenotype is not consistent. Even if you take conditions like homocystinuria, where you expect lens dislocation. Now, I must be having at least 20, 25 cases of homocystinuria, and practically each and every one has lens dislocation. That is consistent. But if you ask me about their arachnodactyly, tall stature, not everybody is having. There are some who are like any other normal person. You don't see them really tall, not like Marfanoid habitus. We really don't see too much of neurological thing. Even though we say they require antiplatelet medication to prevent thrombosis, I have children starting from 2 years to say 25, 30, even one adult of 45 years. And none of them had ever any thromboembolic phenomena. So problem is most of the metabolic diseases describe a list of symptoms or list of abnormalities, and not all patients will have. So I think this is one of the symptoms, but I cannot say that this is the main symptom. The main symptom, if you ask me, I would say cataract and neurological if it is presenting late. If it is a very early onset, like presenting in the infancy or newborn period, cholestatic jaundice, but we have done the reverse kind of analysis. We had some interest in cholestatic jaundice for some other conditions, bile acid synthesis disorders. And that time we used to do bile acids and sterols. And I have not seen any real case or even coming near to suspicion of CTX. It's not that they are not there, but probably the numbers are not that much. So it is very difficult to generalize. We cannot generalize. List is there. Yeah.
Nikhat, yeah. Hello, who is speaking? Nikhat, want to? Dr. Jalan. Dr. Jalan,
Yes, sir.
your adult cases, do
Yeah.
you have any information about the infantile diarrhea? In literature, only infantile diarrhea is mentioned.
No, nobody actually gave this history. Infantile diarrhea or cholestatic jaundice. We have inquired.
Okay,
But it is possible, like it is possible they may not have really paid any serious attention to it. Like having loose motions of 8 to 10 times may not be considered as really something great in Indian society.
Okay.
So yeah, that's true, sir. If you see, sometimes they say, he goes like after every feed. Every feed may be 2 hourly, which is 12 times. And we don't describe the consistency of stools or weight loss.
Yes, yes.
So by number, it is very difficult to judge whether it is really what we are talking chronic diarrhea. Now, weight loss, this particular patient, your Akhil, he said that he had many motions, and after starting colic acid, that has reduced and his weight has improved.
Yes, yes, that's what.
Weight has improved. So this is very clear in this child.
Yeah. Now, Dr. Jalan, when you started colic acid, and his cholesterol level, has increased, and in that cholesterol, HDL is positive. HDL is very high. LDL, there is a marginal increase. And that's why we started, statins. But HDL, such a high percentage, is it common in that age group?
No, sir. No, we have not seen. So what we generally do is we add, like suggest at least, because I don't treat adults. So we suggest you can start statin, and that was one of the papers, if I remember correctly, one of my Professor Weavers from Netherlands, he used to say that if you don't get colic acid or your ursodeoxycholic acid or chenodeoxycholic acid, at least you can start this thing, statin. So the production of cholesterol is reduced, and thereby the production of cholestanol also will be reduced. But this was thought that it is not very effective. So what people did is take this as a second step, not as a first step. So if you get hold of colic acid or ursodeoxycholic acid or chenodeoxycholic acid, start that first. Now, this child showed little increase in cholesterol, which actually I am not really sure whether it is related to colic acid treatment. But it was already in the plan that after 3 months we will add statin. So even if his cholesterol was normal, I would have started. So that was my plan. Now, why he showed increase, I don't know.
And especially as HDL.
That is something one more googly for me.
Very positive, HDL increasing,
but sir, reducing cholesterol is going to reduce cholestanol. So that is, I think, HMG coenzyme reductase. So in that pathway, you are already giving low substrate for cholestanol formation. So that's going to be helpful anyway.
Dr. Jalan,
yes,
now
sir.
In terms of evaluation, you see, this is a long-term strategy.
Yeah.
We are going to take care of ophthalmological evaluation. And neurological evaluation also your colleague is going to take care of.
Yes, sir.
And the metabolism you are going to take care of.
Hmm.
But do you require any cardiological evaluation anytime? In fact, Dr. Sampada, when she has written the second, advice, cardiac evaluation she has written. That, if we think, at what stage we should go for a cardiac evaluation. Is it in the pipeline?
No, sir.
Okay.
Actually, these patients are not really known to be having any additional cardiac risk factor.
Okay.
I don't think that is going to be like, if he has symptoms, fine, but I don't anticipate.
Okay.
I am worried about his only neurological side now.
Neurological side. That is,
Yes, because that is what I expect by second decade. Psychiatric mainly.
Yeah, psychiatric and MRI, neurological.
Yes, so MRI will be required. Yes, sir. MRI, at least one baseline MRI, one after say 4 or 5 years.
Yeah, after that we can also have a second MRI. And these are all for science progress, this type of cases, documentation is very important.
Documentation, yes, sir.
We are following up the patient, in a multidisciplinary way. I don't know how frequently this happens. Yes, any other observations from our colleagues here?
Dr. Rao, I think Dr. Sarojini Jalan and Dr. Vaghu Anand Kumar and Dr. A.S. Kumar, I think they are trying to show interest to speak, I think.
Yes, please. Dr. Sarojini Jalan, madam, you should speak.
No. She is actually not feeling well.
Okay.
She had fever and all. But because the topic was interested, so she said, from my bed only, I will listen to this story.
Oh, madam. Thank you. Thank you very much, madam.
Yeah, yes. She's here in just near to me.
Okay. Thank you. Yeah, we'll share the video to all our colleagues.
Yes,
and
sir.
Dr. Vaghu Anand Kumar, you would like to say something? A final word?
No, nothing, sir. Nothing.
Okay.
Nothing.
Second evaluation we'll send to you.
Dr. Kumar?
Dr.
Yes.
Kumar, yeah. There is another Dr. Kumar.
Yeah, yes, Kumar, sir.
Yes, no.
Yes, Dr. Kumar, thank you for joining after my request.
Yeah.
I think am I audible? Yeah.
Yes, please.
Yeah, I want to know whether if the cholesterol is the main problem, the metabolism, any dietary advice that can help in the long term, like adding fenugreek.
Dr. Jalan,
no, sir. No, sir. See, the problem here is cholesterol, because the block is beyond cholesterol. The cholesterol is important for bile acid formation, and the problem goes in the pathway which is slightly above that. So if we are talking about that, there will be some accumulation of cholesterol which is expected as the effect of this. Problem is, cholesterol comes from the dietary sources. The contribution is 15%. Rest 85% body can make. So even if child is or person is not taking anything related to cholesterol in diet, he's still able to produce about 85% of the cholesterol. Now, here it is not the production that is defective, it is the utilization. So cholesterol now, which should go further and become bile acid, that is not happening. So the logical treatment is statin. So we give statin, the cholesterol production is reduced, and thereby we also tend to reduce cholesterol. Now, if we supplement bile acid, that is the idea of using quinodeoxycholic acid or cholic acid. So use of bile acid, that will be helpful. So you are targeting two things. You are supplementing cholic acid and you are reducing cholesterol, and this will work. Diet, whatever he takes, I don't think is going to make too much of a difference for cholesterol level, and that's not the pathology.
Okay, yeah, got it. Yeah.
Okay, sir.
Thank you, Dr. Jalan. Dr. Jalan, What do you
Yes,
think
sir.
about dosage? This boy, as you know, parent is poor, and suppose 2 tablets. Is there any possibility?
For
Dosages are folic acid.
no,
dosage.
I don't think, sir. Dosage will probably increase.
Increase.
Dosage, I am not really sure.
Okay.
In
It depends on evaluation.
because generally what is, sir, if his levels are say around 2 or 3 milligrams, or sorry, it's a micromole, if I am not mistaken. So if it is in that range, upper normal range, we are happy. We don't have to increase. Now he has come down from 14 to 6, and I want him to come from 6 to 3.
Okay.
And that is why we have increased the dose.
Okay.
After that, the effect of statin will help us understand whether we really need to increase or decrease the dose of folic acid.
Right.
So statins are cheaper, and if that helps, maybe we will try for 3 months, giving him say 1 tablet a day or something like that.
Yeah.
But what I'm trying to do is arrange medicines through some of my patients and friends, and we have some colleagues in US who are ready to help us. The only problem that we see is exporting this medicine.
Right.
So that is now a bigger challenge.
Thank you very much, Dr. Jalal.
Most welcome. Dr. Pranati is also trying to arrange some help.
Pranati has written letter, and they're supposed to get 6 months, supply. I think this is very great. Yeah. But
I think
parents,
let's try this way.
Yeah. We should follow it up like that. Okay. Yes. Any other observations? If no, see what we have learned, in Genome Foundation. It is not that we just give reports to the patients. Usually, the services that are available for genomics, even I have seen cases of NIMS, CDFT, which are government organizations, and the patient is follow up in terms of giving reports. Lot of companies are there which do give reports. Clinicians also give the reports, but in terms of genetics is evolving very fast. Whatever is happening today, tomorrow a lot of change. Unless until it's research supported. So Genome Foundation, fortunately, we have Dr. Gandhi, who supports in terms of research backup. Okay, and we follow up cases. We have more than 30 cases now. We follow up with them. We talk to them, and counseling definitely we have took part. There also one case of xanthamas, hypercholesterol, and 2 sisters has this xanthoma, and hypercholesterol 700, 160, 700, and 300. That is the cholesterol. They went to cardiologist. Cardiologist prescribed statins. And they came back, they went to a dermatologist to remove their cholesterol. And the dermatologist, Dr. Kavita from Guntur, she did that. But also, when she has sent the sample to us, and we found the gene, LDL receptor gene, which is familial hypercholesteremia. So when we have reported to her, and also to the cardiologist again, he continued with statins. But I spoke to the Madam Kavita. She said, sir, I will contact my mentors in USA. She contacted them. And now she has, there is second generation, some drugs she started for cholesterol. Okay. Such type of, what I mean to say is genetics is developing field. And also, unless until research support, and most of our clinicians, they don't have that setup in their organizations where they may be having facilities for DNA testing, but research support, that is what required. And even I know cases, like there are research organizations where DNA testing is done. They do research in this type of diseases. When we asked for critical intervention, they said, this is for research, I cannot share the results. This type of dichotomy is there, but what is we have as a policy in Genome Foundation is that we not only share the reports, but we also have a strong research backup. We talk to the clinicians, we talk to the patients, and see wherever it is possible to help. Like this present case, there are other cases, and this is what our Genome Foundation is functioning. As you all know, it is a non-profit organization, and in fact, some cases, poor cases, we do 50% discount. Dr. Gandhi is kind enough to see to it that poor patients are supported. So with this, friends, I will conclude here. And every month, we are going to have a case study. And also I want, any one of you, among you, you have an interesting case, you can just tell us and you can present the case. This way, usually I contact different dermatologists and ask them if their case. Last time, Dr. Sarath Chandra has reported his case. Now we have, in fact, come out with a mutation for that disease. Earlier, he did some genetic testing, but it was negative report. But we gave a positive report, and we are evaluating the family members to validation. And whenever cause is known, in terms of therapeutic intervention, lot of things are happening. Okay, besides counseling is, of course, we do. With this, thank you very much. And if you know other observations, Dr. Gandhi, we can close. Dear all, am I audible?
Yes, sir. Yes, sir.
Yeah.
Thank you very much, sir. Thank you very much.
Anything further, or can we close here?
Yes, sir.
Dr. A.S. Kumar also joined later, and Dr. Anand Kumar, and all other people who have joined later, I welcome once again and thank you for joining us. Please make this successful because a non-profit, one people and we are trying to support out of the way our own funding, no government funding, no such funding and all that. So please take advantage of this. I request all of you, Dr. A.S. Kumar, who also has a lot of friends in his group. So please take a little extra, walk extra mile to see that we are all supported, and together we'll try to support the society. Thank you, Dr. Kumar, and all the others who have joined. In fact, I think one doctor from Mahbubnagar has joined.
Yes, Dr. Sarath Chandra was there.
Sarath Chandra, yeah.
Yes, sir.
I request all the dermatologists to please support us. Thank you and bye to all.
Thank you very much. Yeah.